Hi everyone, welcome to today's video. My name is Dre and I am a healthcare IT consultant and the founder of Draegan Consulting. And on today's video, I want to talk about the 2020 requirements for the US Medicare Promoting Interoperability Program. So the video is focused on eligible hospitals and critical access hospitals and what their EHR reporting requirements are for the 2020 year. So in summary, reporting organizations need to utilize a 2015 edition CERT. They will report on measures associated with 4 objectives and need to achieve a score of 50 or greater on those objective measures. There are 4 clinical quality measures that need to be reported on out of an option choice list of 8. And there's a few attestations that also need to occur. So that is to attest yes to the security risk analysis measure, to the prevention of information blocking measure, and the ONC direct review. So let's jump into a little bit more detail. So I do want to sort of premise all of this by saying this is just a summary overview, and for detailed information on any of these rules or any requirements associated with this program, I urge you to go to the cms.gov website, and I will put links to all of the relevant components below. But this again is just a summary, so it's not meant to be used as your sole source of information. So timeframes, we're looking at 2 different timeframe periods for objective measures. There is a minimum continuous 90-day period, which is self-selected, associated with those. So any measures that have a numerator and a denominator with them, and there are quite a few, it should be noted that both of those things need to be performed within the 90-day period. That 90-day period is a minimum requirement. You are more than welcome to go over the 90 days if you'd like. You just can't go below that. For clinical quality measures, the period is self-selected as well. However, this one is 1 calendar quarter selection. So it must start on January 1 if you've already started, April 1, July 1, or October 1, and complete within the calendar year. So a little side note on timing, the 2015 edition CERT does not need to be in place by January 1, so if you don't have it in yet, that's okay. However, it must be in place on the first day of the attestation period that you're selecting, and it must be maintained throughout that attestation period. So throughout the 90-day self-select period and throughout the 1 self-selected calendar quarter for the clinical quality measures. For the objectives and measures for this calendar year 2020, eligible hospitals and critical access hospitals, as well as dual eligible, have 4 objectives that they need to attest to, and they are electronic prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. So for electronic prescribing, there's 2 measures that are associated with this objective. E-prescribing, which is worth 10 points, and the query of the Prescription Drug Monitoring Program, which is usually referred to as PDMP. That one is an optional choice, and it is worth 5 bonus points with a yes/no attestation. So in total, this objective is worth 10 points out of the total 100 with a 5-point bonus option. And you'll want to note for 2020, the Verify Opioid Treatment Agreement requirement was removed. So it's just these 2 measures that are associated with this electronic prescribing objective. Health information exchange is worth 40 points out of the 100, and there are 2 measures that are associated with this. So they are to support electronic referral loops by sending health information, which is worth half, and the support electronic referral loops by receiving and incorporating health information. So for both of these measures, there are no exclusions available. All reporting organizations must provide data and attest to them. They are to utilize CERT, of course, as all of these do. And for the sending health information, a summary of care needs to be created and electronically exchanged. For the receiving and incorporating, the big piece is that inbound information on a summary of care needs to be reconciled into your EHR. And the reconciliation components are medications, medication allergies, and current problem lists. So there's quite a bit more details associated with this one and with all the others. I'm not going to, again, dive into the details. They can all be found on the CMS website. And for some of them, this one in particular, I think I might do a video a little later on some more detail, just because I could go on for days and days about this one. So I'll just continue. So the third one is also worth 40 points. It is the highest point single measure, and that is to provide patients electronic access to their health information. It requires that patients be given timely access, so the timeliness of that has not changed from 2019. And they need to be required, or they need to have the ability to view, download, and transmit to a third party. Again, there's nothing new with that. And the patient also has the ability to access using an API application of their choice. So that came out with the final rule associated with meaningful use stage 3. So that is tied to this provider to patient exchange objective. So the fourth one is worth up to 10 points, and that's public health and clinical data exchange. For this one, there are 6 options that are available for organizations to choose from, and there is a reporting requirement to use 2 of the following. So syndromic surveillance, immunization registry, electronic case reporting, public health registry, clinical data registry, or electronic reportable laboratory result reporting. So again, you only have to choose 2 of the 6, but these are the 6. So scoring is worth a total of 100 points. Each organization needs to score 50 or higher to successfully achieve or attest to this program. Scoring is performance-based, so it will be calculated based on the numerator and denominator data for all of the measures that are reported as such. And the yes/no attestations will also be included if there's those. Again, there's those 5 bonus points that you can get for PDMP queries. So keep those in mind. And all of the objective measures must have data associated with them. So you can't sort of achieve your 50 points using the provider to patients and your public health and ePrescribe, for example, and skip the health information exchange altogether. You do need to report data on all of them, so that's something to keep in mind as well. So this just summarizes on a very busy slide, now that I look at it, what those point totals are and how the measures are associated. So again, on the left-hand side, you'll see the 4 objectives. The middle gray section are the measures associated with each respective objective. That's a hard sentence to say. Public health, again, you just pick 2 of the 6, and the point values for each of those objectives are over on the right-hand side. So along with the objective measures, there are also clinical quality measures that are included in this reporting year, similar to previous years. So the number of CQMs has been reduced. It was 16 that you had to choose from. Now that number is down to 8. And there is a requirement to report on 4 of the 8 for eligible hospitals and critical access hospitals. Again, as a reminder, the reporting period is 1 self-selected calendar quarter for 2020. And submission for CQMs can be done using any combination of QRDA1 files if you have data to report, a 0 denominator declaration, or a case threshold exemption. And all the rules behind each of those are again located on CMS websites. So the 8 options for clinical quality measures for the 2020 calendar year are ED2, PC5, STK 2, 3, 5, and 6, and VTE 1 and 2. I'm not going to dive into any details on these ones either, because that would take far too much time, and I do think that I might sort of jump into them in a little more detail in a future post if some people indicate that they're interested in that. So there is a hardship exception for the entire program for eligible hospitals and critical access hospitals. So there are 4 reasons that can be utilized for a hardship exception. And the first one is if a decertified EHR is utilized. So if the EHR that you're currently on at the organization, for whatever reason, is decertified from 2015 edition cert, which I hope doesn't happen to anyone, but if it does, that is available as an option for hardship exception. If there's insufficient internet connectivity, so that one has a lot of rules associated with it as well. Extreme and uncontrollable circumstances, so force majeure type things. Lack of control over the availability of the cert. So if you do have upgrades planned to get to a 2015 edition or implementations planned, and there is something outside of your control that impacts the ability to choose a continuous 90-day period or to utilize a calendar quarter within the 2020 year, those would factor into lack of control over availability and could be considered in a hardship exception application. So last but not least, the attestation deadline for the 2020 Promoting Interoperability EHR Reporting is February 26th of 2021, and attestations must be done using QualityNet. So there is a different deadline if a hardship exception is going to be applied for, but the general deadline for the reporting year is February 26th. So keep that in mind. And your payment year, as always, will be 2 years past the reporting year. So that would be 2022, where you would look to achieve no penalties. So that is everything. So that's just a very high overview. I hope it was helpful. I'll put some links below. If you like what you see, feel free to subscribe to the channel, and I hope to see you again next time.